First problem. When we perform echocardiography in the echo lab, we're looking at the patient under resting conditions. We do not know how the ventricle will actually react when we exercise him. Sure, we can perform a stress echocardiogram, but how frequently do we really do this? So, we do not know anything about the contractile reserve of the ventricle. Problem number 2. The size of the ventricle makes a huge difference with respect to ejection fraction. What I'm showing you here are 4 different ventricles with 4 different sizes, and all of them will be ejecting the same stroke volume. What you see is that each of these ventricles has to have a different ejection fraction to generate the same stroke volume. A small ventricle will be hyperdynamic, and a large ventricle will be very hypodynamic. This is the whole principle of compensation. If a patient has poor left ventricle function, it has to get larger to still accommodate the same volume. This is the way the ventricle tries to keep the stroke volume constant. But it also means that if you have a patient, for example, who has a small ventricle, as in hypertrophic cardiomyopathy, or in a patient who is hypertensive, has a hypertensive heart disease, these ventricles will be very hypercontractile. This in turn means that he's already used his compensatory potential. He cannot increase stroke volume further if the patient exercises. So it makes a huge difference how big ejection fraction is depending on the size of the ventricle. Problem number 3. If we're performing a Simpson biplane calculation of ejection fraction, we're only using the 4 and the 2 chamber view. This means we're not seeing, for example, the posterolateral region, and we're not seeing the anterior part of the septum. In this ventricle, you will obviously get a wrong impression of ejection fraction when you perform the Simpson method because we have a wall motion abnormality right here. This will not be part of the calculation. Interestingly, if you go into some studies that you see published in the literature, you will find patients with coronary artery disease where they looked at ejection fraction, but there's a lot of patients included in these studies that had lateral infarcts. So ejection fraction cannot be representative in these patients. The same is true, of course, if you have regions which are hypercontractile and which are in the 4 or in the 2 chamber view. So we're not really having a complete estimate of the entire left ventricle if you perform a biplane Simpson. Now this is of course alleviated if you perform a 3D echocardiogram, but in most cases we're still using 2D. Let's come to the 4th problem, loading conditions. Pre and after load significantly alter the function of that ventricle. In this case, we have a patient who has mitral regurgitation. Here, after load is reduced. Can we really estimate how good ejection fraction is if the patient is operated? Yes, okay, we say we need a higher ejection fraction to start out with, but how much higher? It will obviously be a difference if patient has severe, very severe, or extreme severe mitral regurgitation. So it's very difficult to judge how the ventricle is really doing. And the same is true for aortic stenosis. Here, obviously, we have a ventricular function which looks worse than it actually is, but how much worse? This makes it very difficult to really determine whether or not the ventricle has already been damaged or not. Problem number 5. Can we trust ejection fraction? Always. Well, what happens in normal daily clinical life? You look at a ventricle and you have this impression of how ejection fraction is. Then you perform a Simpson calculation, and if it doesn't fit, what do? You repeat it, and you repeat and you repeat until you finally get the value that you think is appropriate. So, how reproducible is ejection fraction really? What is the error of measurement, and can we detect subtle abnormalities which would be so important to see if we want to, of course, make a very sensitive diagnosis, and if we want to steer therapy and see if therapy is actually effective? Well, it's not so easy. Here is a 4-chamber view. We gave this 4-chamber view to several colleagues and asked them to perform a calculation of ejection fraction. Now we do see that parts of the ventricle are not really well seen. What did we get? Well, we got ejection fraction in the range of 52 to 68%. Even I was off on times, and the range of ejection fraction was very high. And this is true for many situations. Not only for people who might not have the experience, but even for experts. You sometimes get relatively high variations in ejection fraction.